Hello, my name is Hillengass. I'm the Chief of Myeloma at the Roswell Park Comprehensive Cancer Center in Buffalo, New York. And today I would like to talk about our new imaging guidelines just recently published in Lancet Oncology, imaging guidelines for multiple myeloma and other monoclonal plasma cell disorders. We have chosen to renew those guidelines because we saw that the last guidelines were from 10 years ago, and we saw that the development of imaging techniques went on much faster than maybe even expected 10 years ago. Some of the newer imaging techniques were already mentioned there, but we wanted to put more emphasis on these newer techniques because we know that skeletal survey, which was basically the imaging technique for decades and for the whole time, was really outdated, and we know that from really actually old studies, we know that skeletal survey, conventional X-ray to detect osteolytic lesions in multiple myeloma is a very insensitive technique. We actually know that about 50 to 70% of bone has to be destroyed until you see anything in X-ray, in conventional X-ray. And so the group, the whole international myeloma group, and the people most interested in imaging came together and discussed new ways to recommend imaging in multiple myeloma. One major change compared to the former guidelines is that we recommend a so-called whole body low-dose CT, meaning a computer tomography with a much higher sensitivity compared to X-ray. And in this first slide you can see actually an animation of a whole body low-dose CT where we kind of fly through the body and see the bones in a 3D imaging technique, which gives us much more information about the bone disease in myeloma patients compared to the conventional X-ray. Again, in the International Myeloma Working Group, we had a multi-center approach where we compared patients who had a CT and a X-ray at the same time, and we looked for the sensitivity of both. And we found that 25% of those patients in all stages of the disease, 25% were negative in X-ray but positive in CT. So this, in our view, was really a major point to say, no, we want to go away from skeletal survey and go to a whole body low-dose CT, because it's also very convenient for the patients. They can kind of just have to lie flat on their back, and myeloma patients, because of their bone disease, oftentimes have back pain. So it's much more convenient for them to go into this scanner. It takes only a few minutes and then they are done with that. While in X-ray they have to move, they have to put their limbs and their arms and legs, extremities on the scanners, and this is very uncomfortable for the patient. So we really promote this whole body low-dose CT as the new technique to detect bone changes in myeloma patients. Also, there was further development that magnetic resonance imaging, which was chosen oftentimes for local information, to get local information, especially when there are neurological issues. And also sometimes we already know for several years that the bone marrow, where the actually disease takes place, also shows up in MRI with a very high sensitivity. So we know that we can detect changes in the bone marrow by MRI before there are changes in the actual bone, so that we saw that so-called focal lesions, focal accumulations of myeloma cells can appear in MRI before they have caused an osteolytic lesion. And follow-up examinations that we have published in our group showed that you can kind of predict in some patients, if you know that they are there, you can predict the progression of a multiple myeloma, smoldering multiple myeloma without osteolytic lesions based on those focal lesions in MRI, and also in PET-CT. You can predict the development of an osteolytic lesion in this certain area. So this is still ongoing research, but that has been published in several papers now, that focal lesions in MRI kind of develop further or are kind of also are a prognostic factor for patients to develop symptomatic myeloma. And that's also the reason why in the new guidelines for the diagnostic of multiple myeloma in 2014, the International Myeloma Working Group decided to also put the focal lesions in MRI, more than one focal lesion, as a myeloma defining event, meaning these patients really have high risk of progressing into symptomatic disease and should be treated. So here you on the left side you see a whole body MRI, a conventional whole body MRI, so-called T1 weighted image. And on the right side is a further development. You can see it looks a little bit like a PET, but it is actually a functional MRI called DWI, or diffusion weighted imaging, where we can, by the computer from the MRI scanner, gets information about the movement of water molecules. And as you know, if you have a high cellularity, water molecules can not move that far because of the lipophilic cell membranes. And if you have a lower cellularity in an area, the water molecules can move further, and the MRI scanner is able to detect that and to differentiate it, and we can get some more information, and as you have seen, a very high sensitivity and a very high contrast to see where there are focal infiltrations in those patients. So this is something that's not in the guidelines yet, but it's already mentioned because there are several studies ongoing showing that this diffusion-weighted imaging has a very good sensitivity for myeloma for the bone marrow infiltration. You all know, I guess, about PET-CT, positron emission tomography, combined with computed tomography, and we know that this is very valuable in follow-up. On the left side, you see a patient, a coronal image of a patient before treatment, and on the upper right thorax, you see that there is a focal lesion lighting up. And on the right side, you see that this lesion, the osteolytic change is still there, but the lesion is has much less metabolism, and you can see that this is much less active, and this is after treatment. And here's the same patient with another orientation, and you can see on this side that you have this high uptake, the metabolic activity, and on the other side you have the same lesion but with a much lower uptake, which is very valuable. And it has been shown again in several trials that residual lesions in the PET-CT after treatment are of a very adverse prognostic significance. The thought behind that, or the hypothesis, is that those lesions are kind of the area where those myeloma cells survive, which then eventually might lead to a relapse of the disease. So treating a patient to bring him in a PET-CT negativity is also a goal that we promote in the new guidelines. So here's the first, we decided to divide it into the different stages of the disease and different treatment settings for the multiple myeloma patients. And as you can see here, for MGUS, oftentimes patients come because of an accidental finding of a positive serum electrophoresis, and then we kind of have to decide how far do we go with the diagnostics, because as you know, MGUS is rather common, but myeloma is rather rare, so we don't want to over-investigate those patients, over-examine those patients, but we also don't want to miss something. And so the decision was to recommend whole-body low-dose CT as a rather easy and not very, for the patient, not very difficult technique. So we have kind of a screening in patients with a high-risk MGUS where we say that we recommend a low-dose whole-body CT to see if there are osteolytic lesions. If there are osteolytic lesions, of course, that would kind of show that it is a malignant process. If there are no osteolytic lesion, we can be, and everything else fits as well in the for an MGUS without any signs of multiple myeloma, then we can be very sure that this is okay, and we can just follow the patient. If the CT is not very clear, as I mentioned earlier, the MRI has a very high sensitivity for infiltration of the bone marrow. So an MRI would be recommended in patients where we are not sure if it's unequivocal, if we see something in CT but are not sure, then an MRI might oftentimes be helpful. We recommend whole-body MRI, which is not available of course, in all institutions, but if whole-body MRI is available, that would be our first choice. If you don't have a whole-body MRI, still MRI of the spine and pelvis are also recommended, because you not only see focal lesions, but you can also see a diffuse infiltration where you can kind of estimate if, for example, a patient has an MGUS and an osteoporosis. You can kind of differentiate if the MGUS is causing, or if it's not really an MGUS but a myeloma causing the osteoporosis, which would mean you have a high cellularity, and as I mentioned, MRI is very good to differentiate between high and low cellularity. Or if it has a low cellularity, it is much more likely that it is just an endocrinological or an osteoporosis of the elderly patient. So to differentiate that, the MRI is very helpful in this case. Sorry, that was the wrong direction. For solitary plasmacytoma, if there's one lesion, and oftentimes the patients come to us after they had a biopsy of a single lesion that was found accidentally or because of a swelling or pain, then the patients come to us, and for us it's the most important information we need in a solitary plasmacytoma patient is it symptomatic myeloma with multiple locations, or is it just one location in the solitary plasmacytoma, because our treatment would depend on that. We would rather treat locally with the solitary plasmacytoma and would rather treat systemically in the multiple myeloma. And as you can see, we decided to differentiate a little bit because for an extramedullary disease, it has been shown that PET-CT is a very good screening method. So we can find changes in the extramedullary area in PET-CT very well. In bone solitary plasmacytomas, we decided to recommend MRI again, because as I mentioned earlier, the MRI also shows a diffuse infiltration. So in bone plasmacytomas, oftentimes we find further focal lesions, and we also sometimes find the diffuse infiltration. So that was the basis to recommend PET-CT for the extramedullary disease, and the MRI because of the high sensitivity for the solitary plasmacytomas of the bone. And if you find more in either of those imaging techniques, you can also exchange them. If you have only access to PET-CT, it's also okay to use that in the solitary bone plasmacytoma, and vice versa with the MRI. But that is our recommendation. If you have access to both, that would be the choice that we would recommend. Coming to smoldering multiple myeloma, again, the patient comes to us. Something was found by accident. She or he might not have any signs of symptomatic myeloma, but we have to rule out further, especially bone involvement. And that was the reason why we again recommended low-dose whole body CT as a first screening method. Also for economical reasons, in other guidelines in other countries, sometimes it's recommended to do an MRI first, because as I mentioned, higher sensitivity, and we find changes in the bone marrow before the bone is really affected. But for a screening method, we said, okay, again, low-dose CT, like in MGAS, is our first choice to rule out osteolytic lesions, because as soon as you can prove that this patient has osteolytic lesions and they are really definitely multiple myeloma related, then it would be a treatment indication and we don't have to go much further. For patients where the CT is not very clear and there are changes that are not very clear to differentiate, then we recommend the whole body MRI again to differentiate that, to see if there's a diffuse infiltration, to see if there are more focal lesions, which then again would lead to the recommendation to treat the patient if it's really multiple myeloma. In patients that are positive in CT, we don't necessarily need more examinations. In clinical trials, we recommend a PET-CT because of the mentioned positive information, or actually for the patient, negative information. If there are residual lesions in PET-CT after treatment, there we recommend to have a PET-CT at baseline and then a PET-CT at follow-up, and I come back to that later. So if it's not in a clinical trial, in a kind of regular clinical setting, a whole body low-dose CT helps to differentiate between osteolytic and non-osteolytic activity in a patient, so that would be enough there. But if you have access to a PET-CT and PET-CT is available, then that would be even give us more information on the treatment of the patient, especially the treatment response later on. We discussed a lot about what to do in patients where they have one focal lesion, because the publications say more than one focal lesion is multiple myeloma. One focal lesion might be a plasmacytoma, and if there's more infiltration in the bone marrow, it might be a plasmacytoma with minimal marrow involvement. So there's still this discussion if those patients should be treated systemically or locally first. And for that, we recommend that we go further with, if it's unclear, to repeat the imaging. That is also a kind of a general recommendation. If anything is not clear and we're not sure if the patient really has multiple myeloma and there are no other reasons to treat, sometimes it's really helpful to repeat the imaging, the same imaging technique, or if we have another question, another imaging technique later on after 3 or 6 months, depending on the dynamic of the disease. And having said that, for bone questions, CT is always the better choice, and for bone marrow questions, MRI or PET are the better choices. With PET-CT, we have the combination of both, but the MRI still has the highest sensitivity. But that's just the general information on those imaging techniques. Coming to multiple myeloma, it's a similar situation as smoldering myeloma. Oftentimes we don't know yet if the patient has really symptomatic myeloma. If we already have that, if there are other criteria, for example, hypercalcemia, anemia, or renal insufficiency, then we want to have a baseline. And here, as I mentioned earlier with the smoldering myeloma, we would recommend a PET-CT within clinical trials. If PET-CT is not available, then we recommend a whole body low-dose CT to get this information about the bone disease again. And in advanced disease, as you know, the bones might even have some instabilities, so that's something where the CT and the CT part of a PET-CT are very valuable. Talking about the PET-CT again is we also recommend that the CT part of a PET-CT has a diagnostic value. Oftentimes in PET-CT, in other entities, it's enough just for correction of just to localize the metabolic active areas. It's oftentimes enough to have a very, very low dose CT of the PET-CT. But in myeloma, since we have this important we need this important information about the bone, we recommend that the CT part of a PET-CT, if possible, has a kind of a diagnostic quality. So this is also something I wanted to mention. In patients that are negative, again, to get more information out of that, the MRI is the diagnostic tool of choice to get more information about the bone marrow infiltration. And again, the things that I mentioned in smoldering myeloma apply again. So this is kind of our pathway that we have with a symptomatic myeloma. CT or PET-CT are the first choice. If unclear, an MRI might be helpful. For follow-up, I already mentioned that PET-CT is very helpful, especially if we have an initial PET-CT and we follow up patients. We don't need the continuous follow-up as we did with the X-ray because of the low sensitivity, but we recommend to do a PET-CT after treatment, for example, after high-dose chemotherapy, because we know that, as I mentioned earlier, residual lesions in PET-CT after treatment might be relevant for a progression or a relapse of the patients. There are no clear recommendations because there are no clinical trials on that to further treat a patient or to change treatment based on the fact that we have residual lesions, but we should be careful and maybe do another imaging to see if those lesions are, especially on maintenance treatment, are responding or if they are even progressing. So this is an information that, especially in follow-up, is very helpful. Their PET-CT really is the major player and is the most important technique that we can use. And for relapsed myeloma, again, the major question is if the progression also encompasses basically the osteolytic progression, if the patient have more or larger osteolytic lesions, or maybe even a fracture risk. And here in this case, again, the low-dose CT is the best screening method because you get the highest sensitivity information on bone disease. So progressing a patient progressing serologically to rule out basically osteolytic progression as well, the low-dose CT would be the diagnostic tool of choice. Again, if it's unclear, if we have a situation where we are not sure if the patient is really progressing, an MRI might also be helpful. And in other cases, even maybe a PET-CT might be helpful. If we have residual lesions after treatment, we have to see which diagnostic tool shows it best. So we choose that for relapse as well to get this information on that. And with this, I would like to thank you for your attention. And if you have questions, I think you can find my email address online and we can discuss imaging in myeloma.